Okay, we're now on part 2 of chapter 4. In this video, we're going to go over supraventricular and ventricular arrhythmias. We're going to look at atrial fibrillation, atrial flutter, proximal supraventricular tachycardia. Okay, let's go through our steps. Determine our rate. It's 100 beats per minute, our ventricular rate. We're going to look and see if it's regular. We're going to measure our R to R waves. It is irregular. Going to assess our P waves. There's no discernible P waves. And I have no PR interval. Our QRS duration is normal. Interpretation, this is atrial fibrillation. It's another look at it. You notice that the waves here are very low amplitude. And that's something that'll kind of help you. Sometimes they're so low that they actually may look straight, may not look like waves, and that would be referred to as fine VFib. So just kind of keep that in mind. And we went over already the fact that this is just wavelets that are chaotically forming to create a never-ending cycle of these rapid impulses, which results in this rhythm. And we've been through that. So let's go to the next one. What is our rate? Our ventricular rate is 70 beats per minute. Is it regular? It is. P waves? We have flutter waves. By definition, they're not P waves. PR interval? No PR interval. QRS duration, it's fine. Interpretation, this is atrial flutter. Okay. You have no P waves. Instead, you have flutter waves. Hallmark sign is the sawtooth pattern. So your sawtooth pattern is showing an atrial rate, around 250 to 350 beats. So you've got a lot of fast moving atrial tissue going on, which is, not assisting your ventricles in its job of producing cardiac output for the body. It's compromised as well, just similar to AFib. Okay. And same thing is just going on. It's a reentrant pathway in the right atrium. It happens with every second, third, or fourth impulse. Some of the impulses actually cause the QRS, and others may be blocked in the AV node as conduction moves toward the direction of the ventricles. Okay, let's take a look at this one. What's our rate? It's a little tricky. Okay, we really have two types of regular rhythms happening. A regular slower rhythm, and then it speeds up, but it doesn't lose its regularity. So that'll be significant to help us identify this particular type of arrhythmia. Okay, this is regular. P waves. Oh, I notice that as the rate speeds up, I have P waves here. And as I start going faster, I'm losing the P wave. I have no discernible P waves. Right? And that's going to be, so I'll lose my PR interval when that occurs. My QRS duration, however, is going to stay fine. So remember, our QRS is assessing the activity of the ventricles. So this is still a supraventricular problem. It occurs above the ventricles. And so our interpretation is proximal supraventricular tachycardia. And proximal just means that it occurs quickly, usually it starts and stops relatively fast. Comes out of nowhere. Okay, there we go. And this can be triggered by a PAC that we talked about in the last video. That could be the precipitating factor. Okay. Okay, so now let's go into the ventricular arrhythmias. And I was teaching a class and asked the question, when this rhythm showed up, you know, does your patient have a blood pressure with this or a pulse? And, you know, one of the students said, I don't know, I have to go check. And that's actually the correct answer, because some patients can and some patients, you know, won't. They'll be pulseless. So what you have here is a ventricular rate of 160, and it's regular. P waves are none. So I have no PR interval. My QRS duration is what? Too wide. And that tells you right there that my problem is in the ventricle. My QRS complex has gone past 3 small boxes. So I have ventricular tachycardia. Okay. It's just telling you that this problem is originating in the ventricles. And again, sometimes it can generate enough cardiac output to produce a pulse, and at other times, no pulse can be felt. So, okay, this is easy. Everyone should know this. This is this patient's not gonna have a pulse or blood pressure, most likely, if the rhythm's correct. Okay, so it's irregular. Now, I have no discernible waves or intervals whatsoever. So this is the hallmark sign of ventricular fibrillation. And obviously this is completely abnormal. This is, you know, the ventricular cells are excitable and just depolarizing randomly with no set order. They're just going wild. So you have a rapid drop in cardiac output, and you know, this is a lethal arrhythmia that needs, you know, this patient needs to be shocked. So that is the end of part 2 of chapter 4, and I will see you in the next video.